So today, you're gonna get presented the cervical spine foundation for evaluation, differential diagnosis, and prognosis. So the objectives / student outcomes, students will be able to understand, that's the cognitive domain, foundations for evaluation, differential diagnosis, and prognosis of the shoulder joint complex, and how those foundations develop through performance and application of psychomotor domain that increases from basic recall to complex evaluation and creation. All right, so we're going to start with the orthology of the cervical spine. So we know the cervical spine consists of 7 vertebrae, C1 through C7. The atlas is referred to as C1, which supports the weight of the head through the second facet joint, which forms the atlanto-occipital joint. The axis is referred to as C2, which the superior portion is referred to or called the dens. The atlanto-axial joint is the articulation between the dens and the arch of the atlas. CO, C1, and C2 is actually referred to as the subcranial spine or subcranial region. Again, CO, C1, C2 is actually referred to as the subcranial spine or subcranial region. Who could tell me what CO is? So if you think about the occipital lobe, what of the occipital lobe, what osseous structures articulate with the atlas of the occipital lobe?
I got the complex process of the occiput for the occipital atlanto joint.
Okay, so the convex, what? Facets of what?
The occiput.
Okay, so also referred to as the occipital condyles. Okay. So the occipital condyles referred to as CO, which articulate with C1, the atlas, and then atlas articulated with the axis, C2. Right? They're referred to as intervertebral joints and zygapophyseal joints. The osteokinematic motion for the cervical spine is flexion, extension, lateral flexion, which we refer to as side bending, and rotation. So, interchangeable terminology. Flexion is often sometimes referred to as forward bending. Extension is also referred to as backwards bending. Lateral flexion is also referred to as side bending, and rotation is rotation. So, what is the capsular pattern for the cervical spine? You have lateral flexion and rotation is equally limited, followed by extension. All right. So again, here we go. We have C2 through C7. You have the OA joint, and this is just a diagram so that you all can go back and look at this. So we have atlanto-occipital joint movement, being flexion, extension, left side flexion, and conjunct rotation. So in the cervical spine, with functional and non-functional movement, side bending and rotation occur in the same direction. Well, what is functional movement? What is non-functional movement? But typically with functional movements, we do not move solely in the cardinal planes. We move in diagonal patterns, okay? So for functional movement of the neck, I may look under my arm, and if there's something under my arm, or I'm itching or whatever the case may be, I may look under my arm, say an ant get on my arm, and I look under my arm to kill the ant, or to swipe or hit the ant. That's functional movement because I'm moving in a diagonal pattern, okay? If I'm looking up, and I'm looking up, and I'm looking, so say right now, I'm right here presenting, and I want to look over at this screen. So I'm doing a combination of, I'm looking up, I'm doing a combination of backward bending, rotating left, and possibly side bending to the left. But it's functional movement, okay? Now, non-functional movement is movement that occurs in your cardinal planes. So if I forward bend, that's considered non-functional. If I backwards bend, that's considered non-functional. If I side bend to the left, that's a non-functional movement. Side bending to the right, non-functional movement. So just the standard movements in our planes that we typically do joint range of motion in. So when we assess our patient's joint range of motion, we are actually assessing non-functional movement. Okay? So that's non-functional movement. So again, in the cervical spine, non-functional movement, and also with functional movement, side bending and rotation occur in the same direction. So the loose pack position for the cervical spine is midway between flexion and extension, or midway between forward bending and backwards bending. The closed pack position is extension or backward bending. Okay. So what does that mean? Why is understanding loose pack position and closed pack position important for the cervical spine? So we're going to be examining our component motions in the loose pack position, okay? So why not examine component motions in the closed pack position? There we go, it's already congruent. They are closely, intermittently knitted together, so there's no room for joint play or component motions typically in the closed pack position. So the facet joints are, in a sense, locked down. You can term it like that. They are locked down, they are closed. So really there's very little room for joint play or component motion to be assessed when the joint is in the closed pack position, all right? In fact, many of our interventions, many of our joint mobilizations or manipulations are done with the person in the loose pack position. So you want to understand the loose pack position and the closed pack position of the cervical spine. So here's an example of loose pack position, and here's an example of closed pack position. All right, and here we go, talking about the atlanto-occipital joint. So you have your characteristics and your articulations. So you have a condylosynovial joint that does flexion and backwards bending of the cranium. This is the yes joint, where we do the phenod. So we're talking about CO on C1, okay, when we're talking about the atlanto-occipital joint. All right, so you got your atlanto-axial joint, which is a plain synovial joint. It does forward bending, it does backward bending, it does side bending, and it also does rotation. Majority of the rotation of the cranium happens here. About 60% of the cervical spine rotation occurs at the subcranial spine. Now that is significant because if your patient is lacking in rotation and significantly in rotation, that means you need to know how to assess the subcranial spine. So you have cervical spine, your intervertebral joints, characteristics of an articulation where the superior and inferior surface of vertebral bodies and associated intervertebral disc. So if you look at this characteristics of cervical spine right here, you have the vertebral foramen, and what goes through the vertebral foramen?
Nerves.
So you have the groove for spinal nerve, what spinal nerve? So you got your spinal nerve root, right? All right. You have your uncinate processes, all right? The uncinate processes are significant because if they have osteophyte formation, if they are enlarged or have any type of hypertrophy, they can actually limit side bending. So if you have a patient who has enlarged uncinate processes, you may not get much side bending out of them because the uncinate processes can limit side bending. All right. So again, you have your anterior and posterior tubercles, your vertebral foramen. All right. You have your lamina and also your facet joints. Again, characteristics and articulation of the zygapophyseal joint of the cervical spine. So you have the right and left superior articular facets of one vertebrae and the right and left inferior articular facets of an adjacent superior vertebrae articulating with each other. So here you can see the facet joint, the left facet joint of the inferior vertebrae articulating with the inferior articular process of the superior vertebrae. So the inferior vertebrae is gonna have the superior articular process articulating with the inferior articular process of the superior vertebrae. Okay. Then you have your disc joint, and then also the right facet joint. All right, here we go. The fun stuff: the osteokinematic and arthrokinematic motion. So we're gonna start with the subcranial spine. The subcranial spine can be challenging to comprehend, but once you get it, you got it. So with the subcranial spine, you have the convex occipital condyle, we'll talk about, articulating with the concave, concave portions of the atlas, of C1 atlas. So what are we gonna get? So this right here is my cranium, and this is forward bending. So if I forward bend at the subcranial spine, all right, you have my occipital condyles moving on the concave surface of the atlas. So if I'm forward bending, right, I get a anterior movement, anterior swing and roll, right? And so now, what is my arthrokinematic motion, my glider slide, gonna be with CO on C1? Posterior, okay? So now my occipital condyles have to be able to glide posteriorly. So if I do this, or if I'm gonna limit it to the subcranial spine. So this is a forward nod, or sometimes referred to as nod of the subcranial spine. In order for that to occur, my occipital condyles have to glide posteriorly. All right. Now, I haven't gotten to the atlas yet and what it does, but we're gonna get there. So we got an anterior roll with forward bending, all right? And then we're gonna have a posterior glide with forward bending of the subcranial spine. So what if I do backwards bending? So I'm just gonna do a backwards bend. So this is a backwards bend of the subcranial spine, okay? So this is what it looks like. So this is backwards bending. Do you see what the occipital condyles are doing? So with backwards bending of the subcranial spine, the occipital condyles are gliding or sliding anteriorly, okay? All right, now with side bending right, so I'm gonna side bend right, what are the occipital condyles doing? What do they have to do? They have to slide or glide to the left, because remember, it's convex moving on concave. And when we have convex moving on concave, the slide or glide is in the opposite direction of the osteokinematic motion. Osteokinematic motion, typically referred to as swing and roll, which occur in the same direction. All right, we talked about this in Intro to Ortho. Same thing, same concept for the spine. All right, if I'm subcranial side bending to the left, so this is subcranial side bending to the left. So notice I'm trying not to move the rest of the spine. I'm just trying to move subcranial. So subcranial, very minute movement, just like what Evan is doing. That's subcranial. Good. All right. And so if I side bend to the left, then we know we get a slide or glide to the right. Now, what is the atlas doing? What is the atlas doing? So this is talking about the occipital condyles on the atlas. Okay, good. I can stay right here. What is the atlas doing? So we need to know that. That's not in this slide, so you're gonna have to take good notes. All right. So with my forward nod of the subcranial spine, I have a posterior glide of CO on C1. All right. Now, what is C1 doing? With the atlas on the axis. So the atlas on the axis is gliding anteriorly, because the atlas on the axis is convex on convex. So the atlas is gonna glide anteriorly. It's moving in the same direction of the head. Yes. Okay.
Right, didn't run it back. I'm sorry.
I'm gonna run that back. Okay, I'm gonna run that back. So I'm starting with forward nodding. So with forward nodding of the subcranial spine, we know that with CO on C1, we get a posterior glide of the occipital condyles. But the atlas, it also moves on the axis. So the atlas, it slides anteriorly with the forward nod. So the atlas, think of the atlas moving in the direction that the head moves in, that the cranium moves in. So the atlas has to glide anteriorly. All right. I'm gonna see if y'all can catch on to the pattern. If I do backwards nodding, I'm gonna see if y'all catch on to the patterns. So I do backwards nodding of the subcranial spine. I get an anterior glide of CO on C1, or the occipital condyles on the atlas. Now the atlas has to move or slide in which direction? Posterior, because you got convex on convex with the atlas moving on the axis. All right, so it has to now glide posteriorly. The atlas does. Now, if I do subcranial side bending to the left, right, I get a right glide of CO on C1, right? But what is C1 going to do? It's going to glide to the left because it's following the head. The atlas is following the head. Yes, Jackson.
So it's the C1 on C2 is convex on convex or concave on convex?
Convex on convex.
Okay.
So when we have convex on convex, the movement occurs in the same direction. The osteokinematic motion and orthokinematic motion occurs in the same direction, the same as concave moving on convex. Okay. All right. So if I do subcranial side bending to the right, I get a left posterior glide of OA and then a right glide of AA. Okay. I'm using different terminology so y'all can catch it. That's the osteokinematic motion for the subcranial spine, osteokinematic and orthokinematic motion for the subcranial spine. Now, do y'all want to go a little deeper
Yes.
to get ahead?
Yeah.
Yes.
All right. So with the subcranial spine greatly impacts the mid-cervical spine, right? Because it has to do something with subcranial spine movement, okay? So now, I'm gonna see if y'all can catch on to this. I think y'all can. So if I do right side bending of my mid-cervical spine, and I wanna keep my nose straight, right? So I'm doing right side bending of my mid-cervical spine what do you think my subcranial spine has to do? So CO on C1 has to do something to keep my nose straight. So in order for me to fully side bend to the right and keep my nose straight, my subcranial spine has to rotate to the left. If I side bend to the left, my subcranial spine, to keep my nose straight, my subcranial spine has to rotate to the right.
Is that the Freyd's law in the book?
So the Freyd's law talks about non-functional and functional movement of the cervical spine. Non-functional can also be termed non-physiological. Functional can also be termed physiological. So look at it from that point. That's what it's talking about. So what it's saying is, so it's talking about it from that standpoint. But I don't think it goes into detail about what happens at the subcranial spine with movement of the mid-cervical spine. So the subcranial spine, we know is CO, C1, C2. Typically mid-cervical spine, C3 through C7. Okay, but the movement if the subcranial spine cannot do what it's supposed to do, then we're going to be limited with mid-cervical spine movement. So as physical therapists, we need to quickly screen the subcranial spine. All right, you need to know how to screen the subcranial spine for any deficit at the subcranial spine. Now, if I rotate to the left, what does my subcranial spine have to do? It has a side bend to the right. Okay, so if I'm rotating to the left, I don't know if it's hard to see. It may be hard to see, but with my subcranial spine, for everything to occur how it should occur, I'm rotating to the left, but I'm getting some minute side bending to the right of my subcranial spine. Same thing if I rotate to the right, I'm getting some side bending to the left of the subcranial spine to make that happen. Okay, so look, so that's understanding the subcranial spine. Now, take it again, right? I went back and I said CO on C1. I said that specifically because what's gonna happen, right? What's gonna happen if I side bend to the right, I still got some subcranial side bending to the right. I got rotation that happened to the left at CO on C1, but what has to happen to, what does C1 on C2 have to do? They have to do what? They still got to go in the direction of the head. So they still have to slide or glide to the right. You see? Now that's a nugget right there. Now you really have to probably go back and listen to that. You see? All right. So again, if I side bend to the left, I get CO on C1 will have to rotate to the right in order for me to keep my nose straight. But what's happening with C1 on C2? Gliding which way? To the left. It's going in the direction of the head. It's going in the direction of the head. So if you think about it, the atlas is gonna follow the head. I'm gonna be honest, this is content. This content right here, a lot of entry-level physical therapists may not have a strong command of the arthrokinematics of the subcranial spine. But if you have a strong command of the arthrokinematics of the subcranial spine, you can better evaluate and treat cervical spine dysfunction, okay? Because I see many patients that come to me and they are very, very hypomobile in the subcranial spine, which is impacting the mobility of their mid-cervical spine. And then some are very hypomobile in the upper thoracic spine as well. which impacts the mobility of the mid-cervical spine. But we're gonna get through all of that. But first, you gotta have a strong command of the orthokinematics, osteokinematics and orthokinematics. Now that was right there, that was content, very essential, important content for foundations for what? Examination, differential diagnosis, and prognosis. Okay? All right? So, again, moving on, cervical spine, osteokinematic and orthokinematic motion of the subcranial spine, occipital-olental joint. And so this is a visual for you all. We just looked at this. So right here in this picture right here, you see backwards bending of the subcranial spine, and you see the occipital condyles gliding or sliding anterior with the posterior or backward bend, posterior swing and roll. So you can visualize that and see that. Now, it's also showing you, now this is great visualization for you all. It's also showing you what the atlas is doing. So it's showing the atlas tilting, but it's showing an arrow. What direction is that arrow moving in right here? Posterior. Posterior. So it's showing you that with backward bending of the subcranial spine, that the occipital condyle is sliding anterior because you have convex moving on concave, and then with the convex law, with the atlas moving on the atlas, is going to move in the same direction as the osteokinematic motion. So the osteokinematic motion right now of the cranium is backwards bending. So the atlas is going to go in the same direction because of the convex movement. You can see this. You can visualize this. You see? All right? And at the mid-cervical spine, what you're going to get is inferior, a posterior and inferior slide of the facet joints. So you can see right here, the facet joints sliding posterior and inferiorly on each other, okay? From C2 to C7, okay? So remember I said the subcranial spine being CO to C2 and the mid-cervical spine being C3 to C7. Well, sometimes mid-cervical spine is also referred to as C2 to C7 as well. So don't get confused on that. That's just different from text to text. Okay. So right here showing forward nodding of the craniocervical flexion. So forward nodding or forward bending, where you have a forward flexion or forward bending of the subcranial spine with an anterior swing and roll and a posterior glide of CO on C1. Can you see that? Now right here, what it's showing you that with the atlas moving on the axis, you're gonna get an anterior glide. So remember that atlas is gonna, an easy way to remember the atlas and what it does is it's gonna move in the same direction as the head. So that keeps that simple. All right. And then with the mid-cervical spine, in this case, mid-cervical spine being referred to as C2 through C7, you get a superior and anterior slide. Okay? So you get a superior and anterior slide of the facet joints on each other. Okay? And this one was a posterior and inferior slide with backwards bending. With side bending, so mid-cervical spine, we're talking about C2 through C7. With side bending right, there is what we call a down glide or down slide of the facet joints occurring on each other. I'm going to show you all how to assess this as well and how to treat it. On the right side, we have an up glide. of the facet joints, or zygapophyseal joints occurring on each other with side bending to the right. So my cranium is rolling and swinging to the right. What is the atlas doing on the axis? It's going to go to the west side. It's going to go to the right side. It's going to move or slide to the right side. It has to. And if you go and look at this picture closely, it's going to show the subcranial spine sliding to the left. If you look at this picture closely, go and look at it closely. A atlantoaxial joint being convex on convex, the osteokinematic motion and orthokinematic motion is occurring in the same direction. So I've already actually taught this slide and presented this slide. And so you can go through this slide and look at it, but with the osteokinematic motion, if you get an anterior inferior pivot, then it's gonna present with a posterior glide. What questions do you have so far today with what we've covered so far?
Is there any location in the spine where stem happens instead of wide?
Not to my knowledge. So yeah, not to my knowledge. So when we're talking about orthokinematics, we're talking more specific. So we want to use specific terminology and language. So therefore, we're gonna try to stay away from spin, okay? Because we want to discuss exactly what's going on orthokinematically, and spin is not as specific as what is going on intimately with the with orthokinematics and joint articulation. Because we know, like we hear the term spin like with shoulder flexion, but we know that more is occurring than a spin. You know, we got specific glides that are occurring at some point through the range of motion. Yes, T.
In the book, it says that the atlanto-occipital joint is a bond socket.
So yes, so you have to think about why it would say that. So it's calling the atlanto-occipital joint a ball and socket joint because the occipital condyles are round. Yeah. So they're rounded almost in a sense like the head of our humerus and also the head of our femur, and how they articulate with those concave surfaces. So looking at the concave surfaces of the atlas being similar to the glenoid cavity and also the acetabulum. All right, so we'll pick up here on the next class with the cervical spine, osteokinematics, orthokinematic motion of the subcranial spine. We left off on, we're talking about the atlantoaxial joint being convex on convex. So therefore, with the atlantoaxial joint being convex on convex, the atlas is going to always move in the direction that the head is moving. So with forward bending, you're going to get an anterior glide of the atlas. With backwards bending, there's going to be a posterior glide of the atlas, and so we went over that with the model. With side bending right, there's going to be a right glide of the atlas. With side bending left, there's going to be a left glide of the atlas. Now, this is where the difference comes in with rotation. With rotation, there's something different that is going to occur, and so you need to remember this. With rotation of the subcranial spine and mid-cervical spine, if I rotate to the right, to achieve full rotation to the right, the atlas has to slide to the left, okay? So if someone lacks rotation, subcranial and mid-cervical spine, I need to be doing a screen of the subcranial spine. So I need to know if the atlas is sliding high, it's supposed to slide as well, okay? Now, there's patterns that you can identify that will let you know, okay, if it's the subcranial spine or if it's the mid-cervical spine. But remember that the subcranial spine, according to most literature, accounts for 60% of rotation of the entire cervical spine. You must remember that. So that's significant. So if I rotate to the left, what has to happen to my atlas, right? So if I rotate to the left, what has to happen is that my atlas has to slide to the right in order for me to get that full rotation to the left, okay? So that's something that's different that you need to take note of. Okay? So understanding this slide and the content on this slide is significant. This helps you with differential diagnosis and diagnosis of the subcranial and also mid-cervical spine. So when we rotate to the right, we're gonna get a left glide of the atlas. So what's gonna happen? The ipsilateral facet is gonna perform a posterior glide. So if I rotate to the left, so I'm rotating to the left, right? That ipsilateral facet of the atlas is going to perform a posterior glide. And on the contralateral facet, on the right facet, is going to perform a right anterior glide. Now, what that's going to result in conjunction, that's going to result in the atlas gliding to the left, okay? With rotation right. And it will be the opposite with rotation left. Very, very important. Command this content. Command this content. You're gonna see it now. But the earlier you command the content, the easier it's gonna be to prepare for your National Physical Therapy exam. All right. And this is just a visual on osteokinematics and orthokinematics of the subcranial spine. Y'all can take y'all time and look at what's happening. Because having a visual picture in your mind when you sit down and take a written exam, it helps. Having a visual picture in your mind also helps with the lab practical as well, when you're processing your task that you have to perform. Again, this is another visual over what's the percentage that accounts for rotation in the cervical spine and subcranial spine accounts for what percentage of rotation? 60. Yep, 60%. Make sure you know that. Why is that important? If someone comes with impairment of significantly decreased rotation, say they can only rotate their neck to 20 degrees of rotation. What do we need to be looking at? We need to be assessing the subcranial spine, okay? Along with, our history report, putting everything together. But we do not need to neglect the assessment of the subcranial spine. All right? Now, the mid-cervical spine is referred to as C2 through C7. So when we're talking about C2 on C3 and on down, okay, is referred to as the mid-cervical spine. And you have osteokinematics and orthokinematic motions for those as well. So with forward bending, so you got forward bending, okay. So what you get is a superior and anterior glide of the superior facets of the zygapophyseal joints or facet joints of the superior vertebrae on the inferior vertebrae, okay? With backwards bending, again, you get a posterior inferior glide of both the superior facets on the superior vertebrae of the intervertebral disc. So for the spine, movement is described based on from superior to inferior. You want to notate that. The movement is described from superior to inferior. Okay? So that's how we describe the movement of the cervical spine. So when I talk about what's happening, I'm talking about, say, what's happening with T3 on T4. So I'm discussing how T3 is moving on T4, how T4 moves on T5, how C3 moves on C4, how C4 moves on C5. Do you get my drift? Okay, so that's how we talk about the movement of the cervical spine in regards to how the superior vertebrae is moving on the inferior vertebrae. All right. With side bending to either side, you're gonna have a contralateral translation of the vertebrae on the disc, and so you have an inferior medial down glide of the ipsilateral facet joint, and then you're gonna have a superior lateral up glide of the contralateral facet joint. So we're using the term up glide and down glide. So if I side bend to the left in the cervical spine, so I side bend to the left, on the right side, what I am getting is an up glide of the superior facet joint on the inferior facet joint, okay, a zygapophyseal joint. I'm getting an up glide, all right? And then on the left side, what am I getting is a down glide, okay? Now, I'm gonna show you all how to assess up glides and down glides, because a patient, if they have a restriction in side bending to the right or left, it could be due to a limitation in a down glide or up glide. And also the limitation can be at a particular segment. So you have to know how to assess each segment. Okay, so it may not be the entire mid-cervical spine that presents with a limitation. It could be a particular segment, all right? So just know this terminology of what is happening. So down glide, we got an inferior medial glide, and with your up glide, you have a superior lateral glide of the contralateral side. Now, there's also something, there's pathoanatomy that can play a role with a person's ability to side bend. So this is hallmark. This is something that they love to assess us on. But if you have a patient who comes to you with an x-ray, and an x-ray reveals enlarged or hypertrophy uncinate processes. If a patient has enlarged uncinate processes, then that could limit side bending. And if they have that pathoanatomy, we may not be able to achieve much with improving side bending. So we have to know when pathoanatomy is involved as well. So make sure you go look that up. Uncinate processes, adverse effects of hypertrophy uncinate processes. Then with rotation, you get an anterior superior glide of the contralateral facet joints and a posterior inferior glide of the ipsilateral facet joint. So what does that look like? So I rotate, and I rotate to the left, right? Say I rotate left, and y'all gotta come and get these and play around with them. So I rotate left. What do I get on the contralateral side? So I'm rotating to the left. What does that look like with my facet joints? What are they doing? They're moving where? Anterior and what else? Anterior and superior. Whereas I'm rotating left, what are the ipsilateral facets doing? They're moving in which direction? Posterior and what else? There you go. So you need to know that. All right. Now, in the mid-cervical spine, with functional and non-functional movements, this is key because you got to start putting all these puzzles together. And this is going to get you, this is what you got to think when you're written exam, when you see these written exam questions, because you got to know how one movement can affect another one. But it goes back to foundational content. So in our cervical spine, right, with non-functional and functional movement, side bending and rotation occurs to the same side. Make sure you know that, because that's gonna help you out on your written exam, right? So if a person presents, so being saying that, if a person presents with limited side bending right, and you got the arthrokinematic, if you got both side bending and rotation occurring to the same side, if they present with decreased side bending right, what else could they potentially present with? They could potentially present with decreased rotation to the right. Remember, because side bending and rotation occur to the same side, whether it's functional or non-functional movement. Does that make sense? Okay. So now you start putting puzzles together, pieces of the puzzle together when you work with your patient and assess your patient. So here are visuals, and this is what we just described in word, and this is why I like visuals. This is why I take out these visuals, because you can actually go back and study the visuals to command the content as well. So this visual is showing you that with backward bending of the cervical spine, you get posterior and inferior slide of the superior facet on the inferior facet, going down each segment. And it's showing you that with forward bending, you get a superior and anterior slide, right? Of each facet, superior facet on the inferior facet. So it's showing you that in this slide. But not only that, it's also showing you what's going on with what's happening with the atlas. So remember, we move the head forward. Which direction is the atlas going in? Same direction. All right, it's showing you in the visual. Okay. Now, it's also showing you in the visual what's happening at the with the occipital lobes moving on the atlas. So it's showing you that you get an anterior swing and roll with a posterior slide at the 08 joint. So if you don't do anything, go back and look at these visuals and understand the visuals. Again, this is all described in wording. These are your visuals for rotation, arthrokinematic motion for rotation. All right, and it also shows you what is happening with the atlas as well.